Basically, I would like to present a case. A 64-year-old lady from Cape Town who was diagnosed with seronegative rheumatoid arthritis in May 2010. At that stage, she had quite a lot of swollen joints, an SDI of 42, 43, CRP less than 5, and she had no poor prognostic signs for RA. And treatment was started with methotrexate and gradually increased to 20 milligrams per week. 6 months later, however, she still had an SDI of 42, a swollen joint count of 15, and was therefore clearly a methotrexate failure patient. And she was fortunate enough to be able to enter a golimumab open-label subcut study at that point. After 3 months of golimumab, she had a swollen joint count of 0 and an SDI of 6. But she suddenly developed the onset of interstitial pneumonitis, which was confirmed on the CT. And the golimumab and the methotrexate was stopped on recommendation of the pulmonologist, and she was treated with intravenous and oral Medrol for a month. 4 months after stopping the golimumab, the interstitial lung disease had resolved completely, and she was steadily starting to develop swollen joints again, and an SDI of 36. So at that stage, the treatment options were basically difficult because she was allergic to sulfur products. She had tried Nivaquin and it made her very nauseous, and methotrexate, together with a pulmonologist, we decided we would try methotrexate again. MabThera obviously not being a choice in this patient because she had a negative rheumatoid factor, and together with the pulmonologist, I decided that it wasn't worth risking another TNF. 6 months after stopping the golimumab, Orencia was luckily approved. It was started at 500 milligrams intravenously, and a mere 6 weeks later, the patient was very well controlled with no synovitis, SDI of 4. There has been no reoccurrence of interstitial lung disease after 7 months of Orencia, and the patient remains well controlled until now. And by and large, this is the norm that we have seen with Orencia. Over the last 10 years, I've been fortunate to be able to use it both intravenously and subcutaneously in clinical trials. And this patient, I think, is a good one to discuss because it illustrates a classic methotrexate failure and what do you do then. It also illustrates that DMARD combination is not a possibility for everyone, and that you definitely can see side effects on anti-TNFs, and that there is very good tolerance and success with Orencia in these patients. And it very well illustrates the dilemma we have for the next decade, which is not should we be using biologics, but how are we going to manage the use of biologics. And certainly in my practice, I'm very glad that we have the possibility of Orencia now, given what was said this morning by Professor Yaziki and my personal experience. Orencia is a drug that is easy to use. When your patient with Orencia arrives in your practice, it's one of those patients where you have no apprehension when they walk in because everything is running smoothly, very few problems, hardly any infections. In fact, I've never had to switch a patient that I started on Orencia. So just a little bit of information from my side, and if there are any questions about this case, happy to take them. Yes, Professor. Yes. In our country, we would prefer, because of the cost implications and the success rate not being very high on rheumatoid factor negative. The funders aren't keen.